Hello, my name is Anna Zaldivar. I'm a medical student at FIU Herbert Wertheim College of Medicine in Miami, Florida, partnered with Dr. Matthew Brink from the Center of Excellence in Eye Care at Baptist Health of South Florida, as well as fellow medical students Daniel Aloise, Ruby Hollinger, and Jasmine Nadayil. We wrote a paper entitled Orbital Cellulitis with Periorbital Necrotizing Fasciitis. This case report is centered around periorbital necrotizing fasciitis, which is a rare but rapidly progressive, highly destructive, and vision-threatening infection of the tissue surrounding the eye. The following unusual case presentation highlights the necessity of prompt treatment to prevent permanent vision loss secondary to orbital compartment syndrome. A 55-year-old female presented to the emergency department with left periorbital edema and ophthalmoplegia one day after recovering from a sore throat, which began 4 days prior. She denied any past medical history of trauma, prior surgeries, allergies, or medications. Physical exam revealed a woman in moderate acute distress with severe left periorbital pain and significant inflammation. The globe was tense and the patient had difficulty opening her lids. She was hemodynamically stable, though her visual acuity was limited to only counting the fingers in her left eye, along with restrictive extraocular movements and measured intraocular pressure of 55 millimeters of mercury. At the emergency department, a CT scan revealed inflammatory changes without abscess and an intact globe. Broad-spectrum antibiotics were started for concern of orbital cellulitis. Her vision, initially unaffected, rapidly declined within hours. Her condition progressed to orbital compartment syndrome with an intraocular pressure of more than 50, which prompted lateral canthotomy with canthelysis on the left lower eyelid to preserve her vision. The post-procedure intraocular pressure was reduced to 24. The patient was discharged and provided with medications to prevent infection and further increase in intraocular pressure and to follow up with ophthalmology the next morning. The patient returned to the emergency department the next morning with increased swelling, pain, and erythema surrounding the left eye. She was admitted to the hospital and given ice packs, steroids to relieve the inflammation. Just hours later, intraocular pressure again exceeded 50, so additional lateral canthotomy of the upper eyelid was performed. The patient cultures ultimately came back as positive for Streptococcus pyogenes, with a final diagnosis of necrotizing fasciitis of the left orbit. She was admitted to the ICU for management of sepsis and transferred to the surgical debriefment upon stabilization. Figure 1 shows the patient on admission on day 2 with moderate swelling and discharge from the eye, while Figure 2 shows the patient developing increasing inflammation and erythema. Figure 3 shows our patient after completion of the lateral canthotomy. Here you can see the formation of bullae, which become far more pronounced 1 hour later in Figure 4. These bullae are especially characteristic of necrotizing fasciitis. Preorbital necrotizing fasciitis is diagnosed mainly by its clinical features and has a mortality rate of 14.2%. The clinical presentation can range from mild, localized inflammatory signs to violaceous discoloration and fluid-filled bullae with extensive involvement of the skin. Early recognition and broad-spectrum antibiotic treatment with tissue debridement is vital to decreasing the mortality. CT scan is a favorite imaging modality, but surgical exploration and debridement are the gold standards for therapeutic treatment and diagnosis. This case represents an important reminder to clinicians to consider necrotizing fasciitis in their differential diagnosis in patients presenting with orbital compartment syndrome. Thank you very much.